right. Well, welcome everybody. We appreciate the strong attendance that we have today. It's my pleasure to introduce Dr. Nadeem Khan. Today's topic is orthobiologics. I want to thank Kelly Wood at Dr. Khan's group for her assistance in the background, as well as Kimberly Kerr and John Pettis in my group. I'm Scott Ford, of course, with Ford Richardson. We do mostly workers' compensation defense across the state. As I indicated, we had a real strong interest in this program, and I understand why, because the topic of orthobiologics, I think, has the opportunity to really revolutionize medicine, and I am delighted that we have an expert, a true expert in this area. Dr. Khan is the medical director at the Interventional Pain and Spine Specialist here in Richmond. He holds multiple board certifications, including in physical medicine and rehabilitation, pain medicine, and interventional pain as well. He's been engaged in numerous clinical research topics, including orthobiologics. He's a leader in the area of orthobiologics. He's indicated to me before we went on today that he does want this program to be interactive. We would prefer to use the Q&A, so please, as you have questions, put them in the Q&A, and we'll be sure that Dr. Khan responds to them. And again, we want it to be interactive. I did want to remind folks that this program is being recorded. Credits are being made available. To get the credits, you have to respond to the polling questions that you will see through today's presentation. Make sure that you respond to them. We will be in touch with each of you that have registered appropriately for those credits. And then finally, I just want to remind you of our annual workers' comp program that will be in the fall. As always, this year will be a little different in that we're adding a liability topic the day before our workers' compensation seminar. So as you typically are accustomed, we'll have an all-day seminar on September the 12th, but the day prior, we're going to have a short series on some liability topics. So that's exciting for us. And I will go ahead at this point and turn it over to Dr. Khan to begin the presentation. Again, thank you, Dr. Khan.
Thank you, Doctor. Thank you, Scott, for letting me have the opportunity to speak today. This is a very interesting topic and a burning topic across the societies which handle all the neuromusculoskeletal disorders. And people call it regenerative medicines, interventional orthopedics, orthobiologics. So is it a new topic? No, it's been in our human bodies since we are born. So just the knowledge is becoming more and more prevalent, as well as the interventions are becoming more and more, so that we can have a more scientific information, more scientific data, so that we can help the patient and the population better in a least invasive way. So we are going to go in quite a few questions, answers, so that I can make sure that audience can learn from it today and see what exactly this is all about. As Scott mentioned, that I am a foreign medical graduate. I have done my master's in public health from Johns Hopkins University, and then I did my fellowship at MCV and interventional pain and spine. I got board certification in my field, which are applicable, as well as in my independent medical examinations. My main interests in handling patients for the last 18 plus years is all neuromusculoskeletal disorder, including brain injuries to spinal cord injuries to spine disorders to all these joints, bursas, ligaments problems. So next. What we are going to cover today in this webinar is that how long these treatments are around, where it comes from, what are the sources of autologous biologics and allogenic biologics, what is PRP, what is the FDA standing on these biologics, how many clinical studies are done, how many randomized controlled trials are done, and what is the cost of these interventions, and comparing with the surgical interventions. They are in conjunctions alone, or gonna help the patients better, and keeping in mind the cost of the treatments. And who should be administering those orthobiologics is very, very critical in entire thing, so that the better expert, the physicians who administer them, the better outcome is. So people who are trained to do those treatments should be administering them with a proper diagnosis and looking for the positive outcome. Next. You guys all know that there are multiple previous treatment or conventional treatments in around. These are the conventional treatment, like using over-the-counter medications, Tylenol, Aleve, Advil, then prescription strength non-steroidal anti-inflammatory, then steroid, short and long-acting, and surgical and non-surgical intervention. So where the biologics stays in these treatment, what is the role to help the patient, and where we can fit that treatment in our treatment paradigm. Next. So this is just a schematic diagram I made, and you can see in a human body that these biologics are administered at multiple body organs, and these cells are these allografts are very potent in healing multiple areas in the body. Next. So a little bit going on the history of the regenerative medicines, or how these things happens. If you go in, it is a common, and in a multiple literature has written about the ancient Greeks that the regenerative medicine does occur, and they were seeing that the liver, if it get damaged, it heal on its own. If the incisions happens, if the wounds happens, they heal on its own. That is basically a regenerative medicines. In orthopedic part, it is also goes all the way to the 500 BC. Modern orthopedic therapies of the regenerative medicines goes back to about 80 years ago, and recently, or within last 4 or 5 decades, the debridement of the knees, or cartilage drilling, or prolotherapy, microfracturing those cartilage, all come into equation. But the basic for these all treatment is your regenerative medicine, and how those cells, how those growth factors, how those interleukins and all these substances helps the patients. So this has been around, but now we are more materializing it and learning more about it, so that see how the science works. So what is the science behind it? People at that time may not know much, and people in future may be even knowing better than what we know today about these regenerative cells, which can help to regenerate. Next. The purpose of this regenerative medicine is to focus on the initiate healing, PRPs, mesenchymal stem cells, how they introduce a healing, how they help the people, how they help the tissue healing. We still have not like one confined and 100% that this is the treatment. We are still struggling in our regenerative medicines to find where it stands in the current algorithm of treating paradigm. If you see the slide, that there are like national heroes or national fame for sports athletes, when their shoulder got injured, when their knee got injured, or their hips or cartilage or meniscus or ACL, they did get the stem cells treatments so that they can heal quicker, so that because they can't afford to stay out of that their sports. Next. So first thing to learn is what is exactly the stem cell is. Basics. If you just remember 3 things: a cell which are unspecified, which are undifferentiated, and they have an ability to differentiate. Undifferentiated cell can ability to differentiate, and they can replicate. Next. And if you see in this slide that the cell which I highlighted, a single cell that can replicate into multiple cells, and it keep growing. The one can replicate into two can replicate. So the triple effects is there. And not only replicate, the same cells can differentiate into the environment which it gets injected or it get allocated. These cells can proliferate and differentiate into different structures and different organs. And that is what we call basic definition of a stem cells. Next. Now there is a word called autologous and homologous. This is gonna come across a lot, but more recently the homologous is replaced by allogenic grafts. So autologous, when the blood is collected and reinfused of the patient's in own body parts, his own blood, is called autologous use of the blood. And homologous are more into that collecting from someone and infusing into a blood of a compatible donor, him or herself. So this is two options which come autologous and homologous use. So if I'm saying autologous use, mean the blood of their own and being infused into the same patient, and allogenic when it is from the other persons or other people of the same species. It's not like rat blood can be injected into the deer blood. No, it's just like have to be the same compatible donors. And I'll go into detail later in that slide. Next. Now, this is just like a slide showing to you guys that in our embryo and during maturation and adult, during embryo, if you remember that zygote get formed by sperms and egg, and then there is something called morula. These are all embryonic stem cells, which morula can differentiate into blastocyst. And blastocyst embryonic stem cell, which basically goes to ectoderm, mesoderm, endoderm. The reason it is important to understand that these are so powerful cells that they've manufactured us in our mother's womb. And these cells comes into us as well so that we can continue to repair ourselves for any damages happens to us. So you're going to remember things called multipotent cells, progenitor cells. These are same thing, like they can differentiate into different organs. Next. Now remember that first is the embryonic stem cells, and now these are the adult stem cells. They are found in all overall body. These are all, like I said before, autologous, which when it comes from our own body, and from where they can come from is a bone marrow and fat. Bone marrow produce a continuous flow of our mesenchymal stem cells, and there's also called hematopoietic stem cells in there. Fat has an abundant source of mesenchymal stem cells. If you compare bone marrow versus fat, the fat has more and in larger quantity than bone marrow. These are the multipotent. If you go look, remember the previous slide, I saw those are multipotent stem cells because they can mature into, they cannot be rejected. And the best thing about it, there is no ethical issues and no moral obligations because it's a patient's own blood and its own cells.
And Dr. Khan, by way of example with the knee, when you inject the knee with stem cell, does it actually improve the cartilage?
When we inject in the knee, when you're gonna, I have a few slides which I made later on. There is a concept called regenerate, and this concept called repair. Is that repair is equivalent to regeneration? When the cells are able to regenerate, mean it's gonna get the same quantity, same functionality cells back into the same area. We call it regeneration. When it is coming only repairing the damage, then it's called repairing that. The stem cell does both.
Very good.
So like I said, that these are the autologous cells, adult stem cells, then they come from the same blood and cannot be rejected, and there's no more obligation. And next next slide as embryonic stem cells. And like I said that before, if you remember the third slide in the past, that these types of cells come from the pluripotent stem cells. And there are some ethical and moral issues with that because people do not want it to be like come from that aborted fetuses. They do not want to get from that like abortions. So there is more like into more ethics involves get into these embryonic stem cells. And there is a risk of more forming teratomas from it because these cells can be different from the host DNAs, and that can leads into different kind of variations in that. Next. Now look at this slide that these are the, I'm just giving you the mesenchymal stem cell. When I say I'll short abbreviate as MSCs, the purpose of saying MSCs is a mesenchymal stem cell. Now, if they goes into the cartilage, they can turn into chondrocytes. If they goes into the skins, it can turn into blastocysts, fibroblast. And when it goes into the central nervous system, they can become an astrocyte, which basically regenerates your damaged nervous structures. And when they come into the fat, adipocytes. In ligaments, Again, the fibroblasts repair the ligaments. Next. So these cells has a potential of differentiating into the cells or the area or the tissue they goes into. Now, what is this like? There are how many we cells have in our body? 40 plus trillion these cells are in our body. These cells eventually, all cells in our human body, including brain, skin, eyes, muscle, ligament, heart, kidney, liver, they all get replaced. Every single cell has its own age and they died. And because of our stem cells sitting in our body, we get it replaced. If the dying cells cannot be replaced, the organs start failing. I'll just give you one tiny example. In our kidney, we have 2 kidneys. We just need 1/4 of the kidney to live a functional life. So see how much functional reserves we have. And when those 3/4 of the kidney is gone, it means those cells have died and they are not getting replaced. And then the organs start getting failed. So what we do in organ failed, we do organ transplants. We bring the whole big chunk of the cells, which are like a liver cells or a liver, we transplant into those failed organs. And on the flip side, stem cells carrying in a very good promise that they can maybe able to regenerate that damaged structures if they are given in a fashion that they can not only build or regenerate the new structures, but as well as they create an environment where that damaged or newly formed cells can survive. Next. So what is basically aging? Aging is that inability of various type of stem cells to continue to replenish the tissue of an organ with functional differentiated cell capable of maintaining its original function. That's a word thing, original function, right? That when that original function is not maintained, we start getting wrinkling in our skin because collagen in our skin and fibrin in our skin has its function that it keep our skin stretched. But when we are not able to maintain it, this is called aging. Yeah, I mean, we can do those Botox to stop those wrinkles, but those cells are basically losing their functions. And some stem cells are way in abundant in the younger people. And as we get old, the quantity as well as the quality of those cells is not as we are in our teenage and as we are in adults. Next. So aging is simply stem cells tend to lose the ability to differentiate and replicate. Failure to replicate and differentiate. So what I did in the first place, what is the definition of stem cells? The cells which are undifferentiated can differentiate and replicate. If we are not able to do that from our brain to heart to ligaments to muscles, bones, we are getting older. Next. Now, this is important to understand that when the injury happened, what happened? That macrophages from the blood, platelets comes and they start healing that damaged structure. For example, somebody get a wound infection in the skin. We have the epithelial coating on our skin. If that is lost, what happened? Your blood release those fibroblasts, macrophages, platelets, and they attract those growth factors, interleukins, necrosis factors, and they recruit all the inflammatory cells just to repair it. Next. Now you can see in this slide, there's a bleeding happening, bleeding and then blood clot happen. Who makes the blood clot? Platelets, they get into that area, they release the ADP, and then they start adhering with each other, and then make the blood plug so that the bleeding should not continue. And now the wound has to heal. Inflammation has to get formed there. The inflammation has to create and recruit those fibroblasts, and they come and they release those growth factors, and ultimately leading to inflammatory reaction, to proliferation, and then also the scab get formed and then to remodel the skin. So that is all the process of wound healing happen with what? With all these our body cells, including from platelets to fibroblasts, to collagens, to fibrin, and those mesenchymal stem cells. Next. These cells are proliferating constantly and running and repairing. Like I said before, that every single cell tissue is out in our body died. So these cells are worried more about repairing more vital organs. for example, heart, for example, eyes, brain. These cells are repairing those cells continuously and replacing them. And they ignore the least important thing which we are facing in our musculoskeletal problems, in ligaments, bone. They put on a back burners. Like Scott asked in the beginning, what is this the cells do in the knee? They not only repair, they also do the regeneration. So the difference in repair and regeneration, I'll highlight it in this slide. The process of exchanging a mature injured tissue for one that is immature of different structure is called repair, and regenerate injured tissue for one equally mature and identical structure. So this is what we have, regenerative medicine is basically regeneration and repair both in combination. So the goal is to get those areas in our body which are damaged and not performing its function. Knee function is what? Mobility, standing, and range of motion. If they are not doing because it is lacking the strength or lacking the pain, then these cells help to repair that. Next. Now, like I said, response to injury. Now, I try to highlight in this slide is that when we are in a young adult age and when we are in young age, you can see that how much regenerative potential we have in our embryo or in our early life. When there's acute injury happens, we have trillions of cells in our body which regenerate and lead no scarring. And in adult age, when acute injury happens, because of we are not as having a large quantity of cells, or the cells quality is down, then the regeneration is slow, and fibrosis and scarring is common in those areas. And the goal of this regenerative therapy is to bring it back where we were, to make a regeneration medicine and make a regenerative cells so that we can regenerate those tissues and lead to these fibrosis into least amount of scars. And next slide. So this is the paradigm we need to restore, renew, and recycle and repair, leading to replacement and rejuvenation of these cells. So this is like a whole thing, which the purpose of these stem cells engraftment, that how can we regenerate the damaged structures? Where should we get those tissues or cells so that we can repair the damaged structures? Next. So where are we now? Where and what we're doing now? Currently, we care about this back, neck issues by using this diet, exercise, supplement, medications, injections, surgeries. That is what we are conventional treatment happening now. I will go into detail later when I do those scientific studies to see what support what. But now we are trying to, if the knee is injured, instead of repairing it and bringing it back to the normal function, we are replacing it. If the liver stops functioning, we are doing organ transplants. It could be the allogenics, right? And then if we are trying to get those mesenchymal stem cells derived from the bone marrow or fat, we try to repair those things. So that is what we are doing now and it will be in future.
Dr. Khan, real quick, is allogenics PRP, is that allowed, or is the FDA not allowing that at present?
That is exactly the next slide is.
Okay, go ahead. Go ahead. Yep.
No, you have a very intelligent question. That's why. Next slide, please. So next. Here is those, like what you asked, autologous blood, when you have your own stem cells. Where do we get them? From the bone marrow and from the fat, right? There is no FDA approval needed for that. Okay. And when we get it from, FDA comes into play when we get those cells and try to culture them to produce in a large quantity and put back. That's where the FDA comes into play, that, okay, those cells supposed to be regulated, that, okay, are there cells there? Are they handled properly? If, let's say, if they are taken from a human body in a sterile condition, they are least manipulated. And then when they say that we grown these cells from 1 to 1 million, the claim is correct. And when they're put back into the body, it is done the way it's supposed to be. So the FDA regulations comes into play at that point. So like in this slide, bone marrow aspirate can do two things. One, it is just like we can aspirate from the bone marrow aspiration concentration includes mesenchymal stem cells, right? and they do not require FDA approval. Same thing, we can draw those stem cells from our fat. That does not require FDA approval because this is your own autologous blood. There is no reason to worry that they are not teratomic, like cancer formings, and there is no different DNAs. That is just like there is no FDA regulations in there. Stromal vascular fractions does not require any FDA regulations there. So cell cultures, that becomes, you are culturing mesenchymal stem cells or adipose stem cell, mesenchymal stem cell, then you require that culture, and that's where the regulations comes into play. And this is the next slide. So this is in the FDA regulating those cells by 361 regulations. I have a few slides on there because I will share that if I have a time later, but those are regulated under that category. If they are allogenic, FDA regulations applies there. And they, like, for example, there are 3 allogenic grafts approved for wound care by FDA. And there is a slides coming that was showing that what would the forecast going to be there. And the common OrthoBiologics use is just like I'm mentioning, is that you can products with the mesenchymal stem cells. What are those? Culture expanded mesenchymal stem cells that require FDA supervision and handling and approval there. Engineered mesenchymal stem cell required. BMAC, no, there is no need for that. Stromal vascular fraction, when we drive those cells from the fat, does not require the FDA in there. And microfragmented fat graft, yeah, require that. Like you mentioned, PRP is your own blood. You cannot, I cannot have the PRP of you and inject into my body. That is no, it's not allowed. Right?
Dr. Khan, a question popped in dealing with the issue of the FDA, and somebody indicates that the FDA, and they've quoted it, regenerative medicine therapies have not been approved for the treatment of any orthopedic conditions such as osteoarthritis, tendonitis, disc disease, tennis elbow, back pain, hip pain, knee pain, neck pain, or shoulder pain. Is that correct? And you have any thoughts on the FDA's restrictive position, it seems, at least with, I guess, particularly with the allogenic therapies?
FDA has not approved any allografts at this time for the use of any musculoskeletal problems. Like someone who mentioned in the question, that is correct. They have approved the few treatment for wound care in the skin. Those FDA has approval for those use of those stem cells, non-healing ulcers due to vascular problems, diabetics. We can use those stem cells, same allograft from amniotic fluid or placenta or chorion membrane. These manufacturers are making it, and they are not using them as a cell. Cell has its own definition. Like I said, it can proliferate and replicate. And these allografts do not contain cells, and there should not be any cells in there. They should be allograft. Allografts are very rich in growth factors, interleukins, which repair the damage, not regenerate the damage. So that is correct. There is no FDA approval. But there is another thing, is that FDA does not regulate medical practices. They only regulate your drugs. In my medical practice, if you come and you want to get it done, and I give you clear, clean picture that this is not FDA approved, and this is the off-label use of these medicines, and this is what it is, then it's between the patient and the physician.
Yeah, and I suspect some may say if it's not approved by the FDA, then it doesn't have good science behind it. How do you react to that?
What I react to that, in the world, if you see that so many trials has been done, multiple mesenchymal stem cell therapy have been approved in Korea, Germany. That's where the Kobe Bryant went to get the treatment. Yes, we here have to clearly tell the patient that no, I cannot, like, okay, that amniotic fluid allograft is approved for the disc treatment, and I can do that, and this is a falsification, and I'm lying to the patient, and that is not permitted. So as long as you're telling patient that this is what the off-label use is going to be. For example, gabapentin, is the FDA approved that for the radiculopathy or neuropathy? No. Gabapentin is used for seizure disorders. We have to tell the patient this is not FDA approval. like Cymbalta, approved for your back pain, neuropathy, depression, right? So we use all Topamax. Topiramate is not used for radiculopathy. We use for basically the migraine prevention. So these are off-label use of medicines every time, but we have to tell the patient these are off-label use. FDA has not approved that for that reason. Problem, pathology, yes, we are producing. Later on, you will see my slide that there are guidelines and there are level of studies which support that. And like FDA has in 2019 projected there are going to be 20 or about 25 gene or stem cell therapy will be available in 2025. The research is in being progress, is being done.
Yep.
Any other question on this one right now?
Not right now.
Okay, so here is one other thing I like to highlight in this slide is called alpha-2 microglobulin and PRP. Now, alpha-2 microglobulin is anti-inflammatory molecule. Now, when I make the PRP, what is called PPP, platelet pool plasma, that microglobulin is A2M is in there. That basically have proven scientifically, not FDA, but scientifically proven that it helps to prevent the damage of the cartilage if we inject that one, because this is we derive from that protein, and it helps. It's like a protease inhibitor kind of effect to help to prevent the damage. Ideally, that if I put PRP in the knee and A2M together, one regenerate the areas and help to survive those damaging cells, and the other one help to further not getting it damaged. So next slide, please. So these are the 4 regenerative medicines, biologics being used currently in America. The PRP, everybody is using it. And with the patient's consent, we draw the patient's blood, bone marrow BMAC, bone marrow aspirate concentration, and then the stromal vascular fraction from body fat and amniotic fluid concentrate. And next, please. What is PRP? PRP is that we draw patient's blood, we centrifuge it in a special centrifuge, and we get a middle buffy coat, which is very rich in platelets. The red blood cells are the heavier than the platelet, and then the platelet poor, that all the WBCs, white blood cells comes into there. This is where the platelet poor plasma, where you have the alpha-2 microglobulin. And this is the platelet rich. This portion in the middle buffy coat, that is what we aspirate from that centrifuge and inject back into the patient. This is the platelet rich plasma. That is now have a proven science behind it, that even TRICARE approves that for the knee osteoarthritis, because there's a strong study for it. And insurance is more TRICARE, I think the only one is covering, but other than that, everybody just like who wants it, and I have a very good results with it. Patients come and they pay cash and they get it done. PRP is being used everywhere, from skin rejuvenation to hair growth to damaged cartilage and partial tears in the shoulders or tennis elbows, things like that. Next, please.
Dr. Khan, you had another question come in. Are PRP injections only for knees, or can they be used to treat other joints like wrists?
PRP can be used, like I said, starting from hair growth, skin rejuvenation, shoulder tears, tennis elbows, wrist osteoarthritis, and small joints people are not doing. People are even injecting in epidural spaces so that they can help to decrease those scars from different areas or from inflammation or surgeries. So PRPs for the knee is the only one TRICARE approves and covers it, pay it. You can use it ankle. People are using it even for the skin rejuvenation.
And do you think it is extracting it from the fat superior to bone marrow, or what are your thoughts there?
So that is you're talking about the BMAC, bone marrow aspirate concentration versus stromal vascular fractions, right? Both has stem cells. Fat has more than bone marrow. So fat aspiration, which fat you use? Mostly your abdominal fat or buttock fat. So you aspirate that and you process it and get that stromal vascular fraction, and you inject back there. Now, on the other side, next slide, if you see, that's a bone marrow aspiration. How do I take that? Bone marrow aspirations come from your pelvic bone. If you see that we aspirate that with that needle and get those cells in that syringe, and we process it. The bone marrow, mostly people use a pelvic bone. Some people also can use tibia, but the tibia has even lesser amount of your MSCs in there in that BMAC than the pelvic one. But fat in the abdominal wall has more those MSCs than the bone marrow itself. Next. This is what we do, that I draw the blood from the bone marrow and we process it and get that concentration of those mesenchymal stem cells. And I have done quite a few of that in injecting into the discs or into the nerve scar tissues. So that is how we process to handle. It takes about, let's say, draw the bone marrow, concentrate and process it, take about an hour or so. You can inject 4 hours at the maximum. Once we draw it, 4 to 6 hours for the maximum, it can stay out of the body, and then you have to inject. Otherwise, the cells start dying and rupturing and releasing their growth factors right in their concentrate. And when they go in the body, it doesn't work. Next, please. So this is what you are asking, the fat versus bone marrow. So this is what we aspirate the fat and then get the cells from the stromal vascular palate right here. This is all containing that vascular fraction. And look at all the pericytes and then the stem cells signaling devices in the and even the hematopoietic cells, what monocyte, macrophages, all are in that stromal vascular fraction. Next. Now, amniotic fluid. And if you see, this is just amniotic fluid, allograft, or what is in there. These are all that like epidermal growth factors, granulocyte colony stimulating factors, transforming alpha and beta factors, insulin growth factors. These are all erythropoietin. These are all in the amniotic fluid. Next. So like previous slide saying that, okay, yeah, these are not FDA approved. Are they being used? Yes, they are being used for the degenerative disc disease, joint disease, cartilage repair, tendinopathies, and even for that symptomatic diseases and radiculopathy. So are they being used in the United States? Yes, they are being used in the United States. Next. And that's another slide showing where can you inject that. You can start from cornea, from ocular defects, from the shoulder, people who has a neck problem, neck surgery. We are doing those in the disc in the neck, even after the surgery, even for the cervical radiculopathies. And like you see that ankle, knee, hips, wrist, elbow, all these are being treated before surgery or even after surgery if the scars are not letting the people go back to functions. Next, please. This slide is the same, like commonly used areas are all like I mentioned to you, bro, that starting from the hair growth, sexual wellness, and your skin rejuvenations, peripheral neuropathy, still like not commonly used, but people are trying to see if that any benefit there. Mostly in the spine, the use is in the disc and facet joint and SI joints along with epidural space. Next. So this is what I was talking about earlier, that by 2025, we have a 10 to 20 cellular gene therapy, depending on this forecast was made by the FDA in 2019, that we're going to have this. So the work is in progress and reaching there. And I can tell you that it's going to be a future of the medical management along with AI. Next slide, please. And for reference, I made that this is the FDA where you can go and further explore that regulatory bodies are in the United States, FDA, and in the world is WHO. And like there's no food, FDA has approved MSC therapy on the market in the USA for MSK use. That was the earliest question you asked. So there was none. But are they used for the wound care? Yes, there are. Next, please. And this is the what 361 deal with all these products being used for the musculoskeletal disorders. Bone marrow concentrate and your PRP is fall into 361 products into that category. Next. So this is just showing that, okay, these, what is FDA's worries are, that you do not want the contaminated tissue from other person who has HIV, AIDS, or any other communicable diseases, and you want to prevent the inadequate handling of these processing to contaminate these cells. And clinically, they should be safe so that they can have the normal function and combine with other component therapy to achieve the better metabolic purposes for that. Next, please. Like I mentioned before, the manipulated autologous cells and versus minimally manipulated homologous cells or allogenic cells. That's the difference. That's what we need to be worried, that only if there's under the investigational drug treatment, then the FDA give you the that label that this is the only investigational use for it. And we have used the placenta for that, and that was like we're doing the study on it, that okay, is the placenta derived from the placenta, see if that works or not. So we have to monitor under that study, and the FDA is allowing people to carry out that studies, but we have to inform that is under the investigational new drug protocol from the FDA under their Center for Biologics Evaluation and Research program. Like I mentioned, they're like Apligraf, Cortisol, these are all for the skin products, skin wound damage products, not for the musculoskeletal. Can they use for the musculoskeletal problems? Yes, they can, but you have to tell the patient this is off-label use. Next, please. And this is just like the same thing, investigational drugs and compassionate use is a self-explanatory in there, and it's just like off-label prescribing for the approved.
Dr. Khan, you had another question pop in, and it was if a patient has a history of osteomyelitis, status post-surgery, now 6 years with continued pain and some RTC tearing, would you use his blood for PRP? And if not, would you recommend amniotic as an option?
Both options are there. Once the active infection, no. Once the infection has healed, what is the infection leads to? If you remember that slide where I showed that inflammation and repair and all this, if the infection is there, it means those cells are continuously dying from the infection. So we need to replace that. Once the active infection is controlled, then they can use their own PRP, yes, and they can use the amniotic fluid allograft, yes. Let's say if there is an active wound care and infection going on, then yes, you can use those allografts to help that. And that's FDA coverage for it. And now in this slide, you can see that the work in progress, which we're talking. There are so many trials going on in the world at this time, and China is leading in that one. Almost 200,000 participants are being treated in China and more than 150,000 in here. So these are like, you can see, I'll just put the slide there to see people are into that direction so that we can make our patient to recover better with the least amount of interventions. Next, please. These also falls under the regenerative medicines like irritant therapy. You guys have heard about the ozone therapy, prolotherapy, and I mentioned to you before A2M, alpha-2 microglobulin therapies, because these are the protease inhibition therapies. Growth factors, which are more like those amniotic fluid allograft, platelet-rich, and the stem cells, you can also, like I said, you can also get it from the umbilical cord blood. But that can require the following under 351 category, so that make sure that they are cultured and they are minimally handled, but FDA has not approved to use for the musculoskeletal use. Now, the next slide will show you guys that just to get the idea where these potent stem cells now people or companies are trying to manufacture. One is placenta, other is amniotic fluid, other is a chorion membrane, right? So amniotic membrane. So these cells you can see are having a manufacturing a baby. These are very potent cells. So when these growth factors, they are repairing any damage of the baby in the mother's womb right away. So this is a very rich in growth factors, very rich in cytokines, and extracellular matrix. So stem cells from the buzz tissue do not cause any teratoma like embryonic stem cells. So this is the where the all markets are now kind of working upon to get the graft from here and get it approved. Next, please. And what is in the amniotic fluid? Cytokines, interleukins, chemokines, hyaluron. You know the hyaluronic acid exists in our bones and cartilage. So this is why the amniotic fluid allograft is people are using for the damaged cartilage in the bone, in the hips and knees. Because like I said, the science behind it is the same. Is healing the skin ulcers or skin wound or degenerative tissue. Like I said that before, that the cells in our own body, they are repairing constantly the other important structure. They ignored our hips, knees, joint issues or spine issues. Next, please. So this is a placenta. The first one I showed, the amniotic fluid, the placenta, which also has the same quantity that they can repair and replace. And they do the tissue reconstructions. They have decreased pain and inflammation and help in rejuvenating the normal functions. Next, please.
Dr. Khan, real quick, I think you touched on it, the hyaluronic acid injections, is that taken from your own body?
No, they are making from the rooster cartilage. Right now, those all these, they are made from the cartilage of the rooster.
And we see some of that. It seems a little bit more prevalence in workers' comp as a treatment. Can you just maybe just touch on that? What is that? Are you using that? How is that helping patients? This is the second line of injection therapy for the knee. They are only approved for the knee. They are not approved for the hip or wrist or any of the shoulder joints by the Medicare and FDA. So they are the hyaluronic acid helps to rebuild the cartilage as well as to protect it for further deterioration. They only are beneficial majority of the time if we have a grade 1 or mild OA of the knee and moderate osteoarthritis of the knee. For severe osteoarthritis of the knee, these hyaluronic acid injection, which are we call Gelsin, Hymovis, Supards, Orthovisc, Uflexa, Synvisc, they're like 15, 20 in the market. Everybody's making them. They are approved for the second line of treatment for osteoarthritis, but I have seen that they do work better if there's a mild to moderate osteoarthritis versus severe osteoarthritis. And they help to protect the cartilage and control the pain. Can we repeat that? Yes, we can repeat that after 6 months. And they're coming from a rooster?
Yep. And they're also taking synthetically now. The Uflexa is synthetic. Like
you find the patients wake up at night crowing real loud? I'm kidding. I'm kidding.
There was one, yes. She came. No, people when they come, they said, "Can I have the injection which made from the rooster?"
Right.
I got the rooster injection.
Right.
That's what they come and they do tell. Yes.
Yeah.
You're not wrong. So now this is called exosomes. Exosomes are basically not cells, they are the vesicles. They come from the exocytosis of the cells. These are the messenger RNAs, which basically when we inject, that release the cytokines and they attract your own body cells to come and repair. So the exosomes is also, if you see the next slide, you will see that exosomes comes like a vesicle from the one cells. These are not the big cells, and they go into the like a message, taking a message of the normal cell that okay, go and replicate, so that we need more cells like that, so that we can repair the tissue. These are called exosomes. You might come across that people are using exosomes as well. Next, please. What's the difference between the regular cell and exosome? There's no DNA in the exosomes, deoxyribonucleic acids. Rest is all same. They're messenger RNA, microRNA, and protein in the exosomes. Next. Now, mesenchymal stem cells have been used, or people are using it with their own patient, with the patient consultation, their agreement that they are being injected into the discs. And people are trying to improve those discs by using those, taking your own cells from the bone marrow, processing it and injecting back in the disc. Have I done it? Yes, I have done it. Has the patient improved? Yes, the patient has improved for the target. Yes. Next, and comparing with these with the like US, just I think you are reading my slide before. So there is a comparison. You're saying that if you see the hyaluronic acid, it's a fast treatment time in that, but it does not have any antimicrobial or growth factors in it. And amniotic fluid has all of that. So if I have to choose, and if the patient can afford, I will do the amniotic fluid allograft injection. See, it has anti-inflammatory properties, it has repair properties, it works 3-4 weeks, and it's worked longer. Steroid is a very strong anti-inflammatory drugs and is also active quickly, but this does not last long because inflammation once gone, patient feel better, but inflammation rebuild back again because it's a chronic degenerative processes. And PRP has a growth factor in it which work and start working, but we have to do a little bit like a booster dose on the PRPs for multiple usage of it. And I usually do about 3 to 4 treatment and then every year I do like a maintenance therapy. And I have quite a bit case studies on these things which I can post, and I have talked to my colleagues that let's publish these case studies that we have a good outcome of it.
And this is an interesting slide. You know, we see a lot of steroid injections. Is there a limit that you would say is too many?
Depending the target. Let's say if you are injecting a patient who has a knee osteoarthritis, and I inject the patient with the knee with a steroid, and I get 6 weeks out of it, do I need to repeat it? Answer is no. If I get 6, 7, 8 months out of it, answer is yes, I can repeat that. But I have developed my own paradigm of treating those issues. What I do, I tell the patient that, okay, this is steroid. What I'm going to do is I'm going to inject the steroid and I will see you back in 3 weeks, and I'm going to inject the hyaluronic acid at that time. So that inflammation is gone. So I'll put the other product which I feel that are going to help you to heal the issue or I'll repair it. And I got better long-term relief with that paradigm as just like repeating the injection steroid. That is correct. If you need to, if the steroid is not giving you 3-6 months out of it, there is no need to repeat it as long as you know that the injection was applied at the target, and then it's a treatment failure, not it's a mechanical failure, or it's not like people are not doing proper treatment and expecting good results.
In this country, it seems like our typical protocol for injury is non-steroid, anti-inflammatory, and then the patient seen back, 2 months later. Do you think there perhaps will be a shift to more interventional modalities like you're describing? And why is it that we're not doing that? Because it seems like with some of these other modalities, we could perhaps avoid surgeries. What are your thoughts about that?
I agree with you on that because of the time lapse so much, and with our treatments, what happened is that I'm gonna go back to know a little bit basic science. Our limbic system and our pain perception system, they are very close in our brain. Thalamus and limbic system. When you have an injury going on chronically, you are constantly sending your pain signal through your spinal thalamic tract to your brain. And that starts sprouting some neurons from the thalamus to your limbic system. And people start feeling depressed from it. And depressed people start feeling more pain from it. And there are more chronic wind-up phenomena start happening in your posterior part of your spinal cord. So this is what my problem with this current management system is that patient gets to me 2, 3 years, 4 years later, when the chronic process has already been established. Now reversing that versus patients get at the acute inflammation, acute injury is a lot easy because you want to heal immediately. if you come across that people who have a spinal cord injury, where they go? Urgently into your ICU, and we put in that patient about 1 gram to 2 a day. That much steroids, because we want those free radicals not to damage any structures. Similarly, in chronic musculoskeletal disorders, hips, knee, back, you are correct in that if we know the problem, if we know the pathology, if we can see, okay, let's put the steroid, let's make the use of this damaged structure. For example, shoulder. I do not want the patient with a shoulder pain or acute tear that they stuck there and hold their arm and put in a sling for more than 6 to 8 weeks. They're going to develop a frozen shoulders. So now you have to treat two. One is a partial tear or a complete tear, and another is frozen shoulder. So this is what, like, you are correct in that we need to be aggressive in treatment, but we are not like allowed to do those treatment till we fail 6 weeks of therapy, then MRI, and then because of the other things that, okay, patient get lost in there. In ideal world, that you are on that right on the money, that they should be quickly and urgently treated so that they should not go in a chronic phase. Once they enter in a chronic phase, it becomes fibrosis, scarring. And when the scarring needs to be treated, you have seen in that slide, you need a lot more cells to make sure the scars does not get formed. Scar is not only like we see in the skin injuries, scars form, scarring happening inside the body. And this is now a little bit time to coming for the studies, that all these case studies we have. Next, please. So you can see that, there is like a injection of autologous blood of the bone marrow have been done into the disc. People feel better. Disc pain is gone. Treatment of the autologous blood in July 2015. So 3 studies I have quoted here, this bone marrow concentrate injection into the disc with good outcome. And these are all like, have a good relief even to 3 months, 6 months, even up to 5 years. Next, please. So you can see that if you are injecting your own BMAC, which is bone marrow aspirate concentration or mesenchymal stem cells, they are safe, you are FDA compliant, and your ODIs decreased 72%. People who are in chronic state, these are the chronic people who have a lower back pain for a long time, right? And if you see the next slide, the ODI pain score has dropped down significantly. You can see, read slide itself, that average ODI improved 65%, wheel analog scale improved 69%, and only 5.2% people went for surgery with these BMAC injections, right? How many surgical interventions are being done for degenerative disc disease? A lot of them. Why they don't approve after that surgery? Because that was not the proper indication. If you talk to your surgical colleagues, or degenerative disc disease is an indication. To me, no. Only if you have a nerve pinching and damage happening, then you have to do the microdiscectomy. Fusions over fusions does not solve the issues. And this is way less costly as compared to if you do a full fusion. And this is Dr. Pateen have done the study and showed that there's multiple times, and this was published in 2017, 2015. Next, please. So the conclusion for this one is that treating the disc pain with BMAC has statistically better clinical result than lumbar fusion or non-operative care. I have one patient, which maybe that the case manager on this audience, that I have done a disc injection of the amniotic fluid allograft. That pain was gone. He was offered an extension of his fusion. But right now I'm treating him for that scarred right leg nerve, which is slowly getting better, but not at the speed I want to get it done. Wanted to feel it better, but it is getting there. And there is no other treatment left for like people. Oh, that person has 3 spine surgeries already. So how many you want more? So in these treatments should become available to the people before surgical consultation or before surgical interventions. Next, please. Same Dr. Pateen did the 2 years follow-up. Next, and you can see that there was not only back pain, but neck pain. Patient in significant improvement in the pain after they're injecting those BMAC into the neck. But again, they have to talk to the patient. Next slide, please. We have talked to the patient that this is what you are going to get. Now you can look at this, and this is the ACDF is done. And these people got the injection and they feel better. ACDF did not do much help for that patient because you are immobilizing the whole segment. Let's try to keep the patient in its natural form as long as and as maximum possible. Surgery has its own role, no questions on that. Surgery can help the people only if there is a neurological compromise is happening, if the nerve damage is happening. Next, please. This is a prospect non-randomized data of 182 patients with 97 male, 85 female, and there's a minimum 2 years follow-up with the average age of 55, and you can see the results. Next, please. Average improvement with the BMAC, 63% on the disability and 67% on the pain scale, and no patient has gone for surgery. One discitis has only happened, infection of the disc from the procedure itself, and it was done even 1-level disc, 2-level disc, 3-level disc. So these are kind of data is being produced now that these therapies does work for those people. Please, next slide.
Dr. Khan, before you go to the next slide, you had a question that came in. It said, what are the side effects that can be anticipated from the different injections?
Side effects, like say depending on if I'm using the steroid or if I am using the bone marrow aspirate. Let's talk about the side effect from the steroid injection. The injections side effects are two, one from the needle itself and one from the medications. Needle itself can do what? Infection. Needle, if somebody is not cautious enough, they can damage the nerve if I injecting in the nerve, right? And infection and nerve injury, they can, if the blood vessels in that neural foramen where you are putting the medicine and you are injecting the medicines and you are not aware that AV malformation there, you can start bleeding there. So you can cause the spinal cord injury from it, because if you embolize that injection to the spinal cord area, that can happen. And from the medication itself, steroid can cause you common normal what we called effect, not side effect. Side effects of steroid: increase blood sugar, increase blood pressure. How you're gonna feel a little bit anxiety, jittery, hot flashes kind of feeling, but those are temporary for a day or two. And now going back to that, if I'm doing the BMAC injection, I'm aspirating his stem cell from his bone marrow, risk of infections there. The trocar which I use is not like it's a 17 gauge with the fenestrated holes in it, which aspirate the MSCs. So you can have some bone soreness, but it's only lasts for 24 hours. Mm-hmm. Safest and the effective treatment if done correctly and by the people who are trained to do it. Good. And now I know that you asked me before that comparing with the BMAC with the surgery. So you can see this is a comparison. That BMAC average improvement with 63%, 1-level disc surgery, 74% improvement. So slightly better, but look at the cost. Look at the rehabilitation from it. Look at the amount of time it takes. And reoperation still happened 3%. 2nd-level improvement only 70%. Reoperation 3%. 1-level ACDF improvement 65%. Reoperation 7%. So it does come into play where you want to use the BMAC or where you want the patients go for surgery. I will, maybe I'm biased towards my treatments as compared to surgeons, but surgeons are a good colleagues. They are there to be as your last resort, because surgery does not gonna be like, okay, you go for surgery today and tomorrow you're gonna be free. It's not like an appendix surgery or gallbladder surgery. It's more like musculoskeletal, shoulder, knee, hip surgery. You take a little time to recover from it. Next, please. So the conclusion for this slide is that if BMAC is equal to 1 or 2-level cervical anterior discectomy replacement, and they can be compared that 65% to 70% kind of improvement. And this is just injection therapy. And you start seeing the results in 3 weeks, 4 weeks. Next slide, please. So again, the same thing, that it is equal or superior to any cervical or lumbar surgery, according to the Dr. Petin studies, and it 1 up to 4 discs. Next, please. These are the guidelines have published by the American Society of Interventional Pain Physicians, and this is just like showing what kind of science behind those injections exists. So I just referenced that to guidelines. These are published in 2019 by ASIP. Next, please. Like your next question comes, how many repeat injections required? There is no consensus that you need 1, 2, 3, 4. How many PRP? How many BMP? How many allograft you need? There is no consensus on it. Repeat injection required, yes. But in my case, that I would like to see that if there is an improvement happening, I do not need to just keep doing it and there's no improvement is anticipated. If I get at least 30-40% improvement from the first treatment, I would like to boost it in 3 to 4 weeks of the second treatment. If I get further improvement, then I would like to get improve further. So next slide. These musculoskeletal people are very challenging people. I mean, they are mostly young folks, are a few, but middle age to old age are more. Severe spinal stenosis, degenerative arthritis. I mean, our parents, maybe in the 70s and 80s, they're bone-to-bone arthritis there. They're not surgical candidates, right? So these are the challenging patients, and they have seen multiple medications, polypharmacies happening. That they go to one doctor who add NSAID, other go they add opioid, third go they put the topicals. So it's just like multiple medications have their own problems going through the body. So in order to treat those, we have to have like a very specific plans and upfront given to the patient that this is what we're going to follow, but you have to play your part as well. So going to the next slide, I'm talking about a little bit back pain, that mostly these people have 3 or 4 sources in your back: disc, facets, and SI joints, and the spinal nerves. So these are the relative target of those stem cells. Next, please. So these are just the studies showing that autologous bone marrow concentrate given in the disc, 26 patient, mostly 1 disc injected, 70% has a significant improvement even after 3 years. 40% had regeneration in their disc, and this is also MRI vision to see how much regeneration has improved. The problem with that when we inject, their cells grow. How to maintain that growth? How make sure those cells survive there, that they do not die? That's a key thing, that if somebody is a smoker, those cells are going to die quicker because there is not enough nutrition coming from your body to help to let those cells survive again. Next, please. And this is the 18 months follow-up and showing that 15% who has intradiscal BMAC or PRP, 93% have more than 50% improvement is after 18 months. So these are, although these are case reports, but they are accumulating the data now to get it better soon. Now, next, please. So the disc has level 3 evidence, facet level 4, and SI joint level 4 evidence according to the meta-analysis. So these are like gonna get into the stage when the data can be submitted to the FDA that, okay, approve these treatment. And this is interesting. Next slide, please. Now, the reason I put that slide for all us to know that this is a disc. You can see there is a micro fissuring happen between disc and the bone. These are vertebral body above, vertebral body below. The pink zone is the disc. So when it's a degenerated disc, you can see there is a micro fissuring happen. Now, with the micro fissures, what happened? These discs, which are not talking to the bone marrow, they start talking bone marrow, which leads to more scarring, fibrosis. And that is a new concept, which is called end plate changes. And this is a source of pain rather than degeneration of the disc. So this is like an evolving concept, because if you treat that, and I did treat that, if I see a modic changes on the MRI, I offer the patient, you want to try that allograft, see if that betters. Rather, I have a couple of, one orthopod surgeon, he brought himself and his son.
And I saw those MRI. He wanted me to do the other treatment called Intracept. I said, you want to try that amniotic fluid allograft? He did try, and is 18 months now. He's able to carry down his all-day surgeries. He's able to stand for longer. So these therapies does have the role in treatment. Next, please. Now you can see that when they do the construct of the spine, when the surgeons put the screws in the disc or in the vertebral bodies, you can see that we still have a chance that if we feel that there's a disc pain coming, we can inject in that. And in my practice, I have done 3 or 4 so far, but with the colleagues, when we go in our conferences, they've been doing it, especially in the West Coast area, and having a good results for the disc problems. Next, please. So one high quality randomized controlled trial for epidural blocks and moderate quality observation studies, meta-analysis giving a grade level 4 kind of evidence for epidural injection of the mesenchymal stem cells or PRPs. Next, please. For facet joint, we have a 1 RCT randomized controlled trial, just for your audience, that these are the highest standard research studies one can carry it out. And that's what mostly these insurance companies look for, the RCTs, randomized controlled trial, when the patient can be in the therapy group and non-therapy group, and they try to create the equal environment. And there are 2 moderate quality observation studies with PRP, and we have the level 4 data or the standing on that. And next slide, same thing for the sacroiliac joint. There's 1 RCT and the level 4 evidence with multiple observation studies and 1 low quality case report. Next slide. Now a little bit talk about the PRP. What is a PRP? I know there are questions. So PRP, like I mentioned before, we increase the concentration of the platelet. Platelet are very rich in growth factors. Like I showed in the previous slides, that the platelets are the one which make our plug in our wounds. So these platelets, we concentrate it to 7, 8, 9 times from the baseline, and that helps to repair the damage or reduce the inflammation, and along with regeneration of the tissue. Now, platelets also, there is a thing called fibrin, which is made after the platelet plug so that they can start cleaning the skin. So the fibrin is being studied now, that if we have those tear in the disc, if we can inject that. Dr. Kevin Paula from Florida is doing that studies, and hopefully we have some good results that for all these discal tears, that we can inject that fibrin in the disc so that we don't have to let the patient go for any surgeries for that tears. Next, please. So you can see that the PRP and all these allografts can be in isolation used for the osteoarthritis, tendonitis, epicondylitis, patellar tendinopathy, plantar fasciitis, back, neck, but along with the surgical use. Surgeons do use these products when they do the surgeries. Next, please. So these are like showing how we make the PRP, draw the blood, process it, get the buffy coat, and then inject back into the patient. And next slide, please. This is just like highlighting the traditional treatments of the osteoarthritis of the knee. First of all, we have to make sure that we are creating the environment for the knee not to get further damage. And then we have to work on what the existing problem is, that we have to reduce the catabolism and increase the anabolism, and inject topical therapy, oral therapy, like topical NSAIDs, oral NSAIDs, and then the injectable therapies, steroids, hyaluronic acids, PRPs, and mesenchymal stem cells. These are all, and if they fail, then we have the joint replacements. But it is a good promise that if we are able to save people from the knee replacement, as well as restoring their functions, we are in a big success, because this is a huge cost to those injections, therapies for all the topicals, that if people come mild to moderate OA, inject 1 PRP or MSCs, and people get better 3-4 weeks, as long as they're not doing all of the things, gaining weight, nutrition, exercise, things like that. Next, please. So the paradigm is that oral, topical, hyaluronic acid injection or steroid injection. But I think that should be in near future going to get replaced by these PRPs and stem cells. Now, next slide, please. These does show that these therapies does help and regeneration, and that MRI shows here. Treatment of the knee osteoarthritis with allogenic BMD-MAC. You can see that improvement in the pain, improvement in the functions, and along with that objective evidence that the joint space get better and the cartilage get repaired. So these are the MRI findings of the knee treatment with the allogenic BMAC. Next slide. And now these are the X-rays finding of the same people. You can see the joint space on the left versus the joint space on the right. So these things does help the people grow their jaw bone space. Next, please. You can see the mild increase in the joint space on the medial side of the medial joint space of the knee. So these therapy does help. Next, please. And these are some osteophytes. I try to show that osteophytes do not get any change, but the joint space can get better because the cartilage grows here, meniscus start healing, then the joint space get better. And this is the MRI findings of the knee after the PRP. You can see on A that this cartilage grows in not only in the patellofemoral area, patella and femur. You can see the cartilage on the left side versus right side. So it does help in people in getting that, not only the patellofemoral cartilage volume, but also the inflammation, the synovial membrane inflammation. And that was published 2 years ago. And on the lateral view of the same treatment, you can see that people do have improvement in the size of the cartilage after that PRP treatment. So the articular cartilage thickness using MRI after the second or third grade of osteoarthritis. Next, please. How much time I have? Okay, this is a severe knee osteoarthritis. Like I said, that severe knee osteoarthritis, this is a 30 patient with the intra-articular injection and intraosseous injection. So Scott, what is the intraosseous injection? Not only you inject in the knee, but you go in the bone under the meniscus to repair it. And people who have only the intra-articular injection have 16% improvement, and these are who has intra-articular and intraosseous has a 47% improvement after one year. Next, please. This is the ACL repair. 29 patients with that PRP treatment and BMAC, and most patients that MRI regeneration has occurred after 8 months. Only 17% required surgery. So 29 patients, only 17% required surgery with the ACL injury. Are we not saving here a patient joints? We are, because once you have ACL repair, you're gonna be looking for the knee replacement very soon after that, because the cartilage does damage, meniscus does get damaged. So these therapies does save patients time and money. Next, please. So this is the treatment of the meniscus lesions. So in the knee, you are working on the cartilage, osteoarthritis, you're working on ACL, and you are working on the meniscus. Every 3 front with the PRP treatment, it has helped the patient and improved not only subjectively, but also objectively looking on the MRI. So imagine the potential on this. So next, before that. So potential on these, next please. That these are therapy, next slide. Now look at the potential that how many meniscus surgery per year? More than 700,000. How many ACL repair? More than 150,000. So how many total knees? More than 700,000. So let's look at the impact of just for the knee and the entire burden on the economy. And every 10% of Americans suffer from chronic knee pain above age 50. Imagine the potential of these stem cells that if we start repairing these things without surgeries, how much money we save for our economy. Next slide, please. So this is showing a little bit like, okay, in the hip area, what can we do? In the hip, now getting from knee to the hip. Hip has a femoral acetabular impingement syndrome. Hip has the tendinopathies around it, gluteus medius, minimus, and greater trochanteric bursa. Those, and along with the intra-articular hip pathology, which is osteoarthritis, or if there's a labral tear happening. So if you repair the tear, people still have the problem. Try that first. See if we can repair through the mesenchymal stem cells. And I highlighted how many studies you can see every person has improved. There is a Senator study in which has 216 patients. Next, shoulders, intra-articular and supraspinatus, biceps, subdeltoid, AC joint. These are all 5-6 area in the shoulder we can address by the mesenchymal stem therapy. But at the same time, you want to make sure that if the tendon has completely ruptured and is started to getting retract, then we need to involve the surgeons there so that they can have the, for the patient, they can repair the structure along, they can inject their stem cells to get it better. So what is the future hold for the regenerative therapy? I'll take a couple of slides. So regenerative medicines hold a very promising in delaying or reducing surgical interventions. This should be a middle ground between the spine steroid injection and surgery. The goal will be to moving away from the metal or ceramic joints to the biological treatments and regenerations. We can expect that moving towards the orthobiologic as a preventive measure for degenerative disc disease or joint disease. And difficulties are, FDA is the number one, they want regulatory on that, all these things. Number two, how we can store the stem cell, how we can rapidly grow them by grafting them, how we can prepare them and safely inject to our patients. Next slide, please. Is this an exciting and promising field that may hold expanding the range of minimally invasive treatment options and managing or even curing condition for that our current therapies cannot, steroid, anti-inflammatory, things like that. Now, I just one case study, then I'll open more question answers. So this is a, next slide, please. Is a 54 years old male who has 3-4 episodes of chronic severe acute lower back pain, which lasts about 1 week or so for the last 4 or 5 years. Steroid, oral steroid he was using, and he basically reported that he ran 2 miles, traveled about 10-12 hours sitting on a car, and then came home, ran again 2 miles. Next day he noticed that his right leg started getting numb and weaker, and he was not able to dorsiflex his foot. He's not able to lift his foot. Okay, numbness, tingling, severe pain started. No other significant past medical social history, non-smokers. MRI done for 4 days later, and it shows a, next slide, large herniated disc. You can see this L4, under the L4-5, there's a big extruded disc right there, if you see in this slide, L4-5. Even retrolisthesis is happening, and one more disc herniation of L5-S1. Like the history tell that the 3, 4, 5 episodes. I believe that those disc herniation happen on those episodes. But this one, so he underwent a steroid injection, epidural steroid injection, and 2 weeks later, amniotic fluid allograft in 2021. And now he is having he does not have the anti-gravity strength in his right foot. He was not able to lift it. And now have a normal strength, normal functions, and no residual deficit. And he consulted the surgeon, and surgeon said, I need to do the microdiscectomy right away so that we can take the pressure off from the nerve. But amniotic fluid allograft therapy has done its magic. And that patient is me, myself. And thank you.
Well, thank you, Dr. Khan. We just have, I think, 6 minutes remaining. To the extent there are any other questions from those in the audience, we'll take them. Give a few minutes to the extent there are questions. And while we're waiting for that, to the extent there are any questions, I'll just remind folks of our annual seminar, September the 11th and 12th. Go ahead and mark your calendar. At the conclusion of the program, you will receive an email from us indicating more information on the credits. We did mention this is being recorded. If you want a copy of it, contact John Pettis in my group, as well as the material. We did have a question. Oh, just to thank you, Doctor. Very good. Well, thank you.
I have asked a very interesting question. You have some more?
Yeah, I'm curious because you indicated that athletes are using regenerative medicine. Do you think there'll be a place where folks will use it proactively? I mean, if you feel like a slight, pain in a knee that to get a jump on it. Would that make sense?
It will be an advantageous because when pain occurs in any organ, any body area, we call it as symptoms, right? For example, I have a chest pain. It makes me, okay, what is the chest pain is coming from? Then we go and address that and find the chest pain is coming from heart or lung or stomach or the esophagus or intercostal or cartilage. Then it becomes a disease. Early warning of a symptom that, okay, if somebody has a knee pain or shoulder pain, address it immediately so that it should not go into chronic phase. What normally happens is that when we do not address it, we baby it. For example, shoulder. People start holding the shoulder and start doing these kind of movement. They don't move the shoulder, right? So because they are adaptive to compensate for the lost functions. But at the same time, when they go and see the physician or some other clinical providers, well, you cannot move your shoulder. No, it hurts. So like you said, preventive orthobiologics or things like that, I think that is more like exercise, diet, having a good active life, nutrition, not gaining weight, non-smoking. All these things are more preventive therapies than preventive injection or like, what is this female actor who got the mastectomy? Preventive mastectomy.
I remember you're talking about.
So
Yeah.
I think Angelina Julia.
Yeah.
So those are the things that I don't think there is a role right now being discussed that we should inject the stem cells in the disc to prevent it from degeneration.
The question did come in about cost. The question is, does cost become prohibitive? We know that workers' comp will pay for it in certain circumstances, but what about the general public? Can you speak to cost?
The cost right now, if I have using the amniotic fluid allograft, I think Kelly is the $1,200 per cc.
Yeah, it's about
There's about $1,200 a cc they're costing us, and plus that injection therapy cost. Let's say if I'm injecting 4 discs and 2 joints in the spine or simple shoulder or knee, it depends on that. Let's say if I have to use a 5 cc of that graft in the spine, 2 joints, 2 discs, things like that, and then the procedural cost, and then the facility cost. So it can vary from somewhere, from $7,000-8,000 to $15,000-17,000, something like that, compared to 1 screw in the spine is $50,000.
Well, very good. I think we're just about out of time. We won't stand in front of folks' plans for the weekend here. Dr. Khan, we really appreciate you taking time today and sharing your knowledge. It's a real honor to have this program with you, and I appreciate your time. Kelly, I appreciate your assistance in the background. And of course, on my side, John and Kimberly, we thank you for your efforts. And thank you to all the participants. We had a really strong showing, and we appreciate it being interactive. So thank you, everybody, and we'll go ahead and conclude. Thank you, Dr.
So much,
Thank you so much.
Thank you.
All
Any
right, bye,
questions,
everybody.
Peter, let me know. Thank you.
Yeah, and if you have any questions, I'm sure Dr. Khan would love to hear from you. And Dr. Khan, maybe just real quickly, the name of your practice one more time, so folks, if they want to reach out, they can reach you.
It's an interventional pain and spine practice in Chester, Virginia, and I deal with all musculoskeletal disorders, neck, back, knee, hips, other things. Like I will be prefer to see those patients sooner so that I can save them from surgeries.
And you can be found, I presume, online. You have a website.
IPSSVA.com.
Very good.
IPSSVA.com. It is an interesting topic, but it was such a broad topic to give them just like a ABC of the discussion. Even the knee only stem cell is just one big topic. So happy to discuss later if needed. Thank you so much.
Again, thank you, everybody. Have a great weekend.
Bye-bye.
All right, bye-bye.